All right, can you guys see that okay?
Yeah, that's great.
Perfect. Okay, so yeah, thanks again, Dennis. So I'm going to talk today about diagnostic imaging in infective endocarditis. So, okay, so I'd like to start by discussing where imaging fits in the diagnosis of endocarditis. We'll review the key echo findings seen in endocarditis, then through case examples of TTEs followed by TEEs. I want to show you common imaging pitfalls to be aware of. I'd like to explain how to decide which patients with suspected endocarditis actually require a TEE. We'll touch on multimodality imaging so we understand when other modalities can be helpful. And we'll review complications of endocarditis seen on imaging with both TTE and TEE correlates so that when we're reading TEEs, we know when to suspect complications. So we'll start with the pathophysiology of vegetation. So development of endocarditis really is a complex interaction between microorganisms, valve endothelium, and host immune response. So the process is initiated by endothelial injury and inflammation. That causes activation of platelets, which causes formation of fibrin platelet clot on valves. So bacteria can then gain transient access to the bloodstream through a variety of mechanisms, so healthcare procedures, dental procedures, IV drug use, etc. Microorganisms in the blood then adhere to fibrin platelet clots, leading to valve colonization and biofilm formation. And lesions can then mature into a vegetation. So as valvular lesions progress, they can damage the valve and the surrounding tissues. Complications can occur, such as embolization. And so what's important to remember here is that the process typically starts with an abnormal valve or with prosthetic material. And so when imaging these patients, that's something that's important to keep in mind. So the incidence of endocarditis has been steadily rising over the years for a variety of reasons. So there's been increasing number of patients with prosthetic valves and other prosthetic material. There's increasing number of congenital heart disease patients surviving to adulthood. And of course, there's an aging population. And endocarditis remains deadly. So despite advances in treatment, endocarditis mortality still approaches 30% by 1 year. It's also very costly. So the average hospital charges in the US for a hospitalization for endocarditis is in excess of 120,000 USD per patient. And so therefore, accurate diagnosis really is key as it enables us to initiate prompt treatment. So how do we actually then approach the diagnosis? So this is the diagnostic algorithm from the AHA 2020 valve guidelines. So all patients with suspected endocarditis, of course, need blood cultures, a TTE, a history, and a physical to enable you to apply the Duke criteria. The question then becomes, who needs more advanced imaging? So taking a note here that TEE, cardiac CT, and PET are all listed. And I think this is an excellent set of guidelines, but I do find this flowchart just a little bit complicated, a little bit confusing. So I find the ESC guidelines a little bit easier to follow. So I'm just going to refer to those. I'll kind of jump back and forth between ESC and AHA. So there's actually two separate algorithms in the ESC guidelines regarding imaging test selection. And this is the first one, and this is on how to select patients for a transesophageal echo. And so remember that in general, the sensitivity of TEE is higher for detection of vegetation and complications. However, both TTE and TEE do have their strengths. And so we should really think of them as complementary imaging techniques. So one should follow this algorithm before applying the Duke criteria because it actually enables you to apply the Duke criteria. So let's just take a closer look at the algorithm then. So of course, in all patients with suspicion of endocarditis, do start with a TTE. The TTE, sensitivity of TTE for detecting endocarditis on prosthetic valves and other intracardiac devices is particularly low. So in any patient with a prosthetic valve or a device and suspected endocarditis, they should move on to get a transesophageal echo. In patients with native valves and suspected endocarditis, if the initial transthoracic is non-diagnostic, that's also a reason to move on to a TEE. Now, interesting, these guidelines also suggest that really all patients with a positive transthoracic study for left-sided endocarditis have an indication to move on to transesophageal echo to further characterize the lesion and its size, define the extent of infection, and rule out complications. And really overall, that part is just a little bit more aggressive than the AHA guidelines, and it's one of the main differences. The AHA guidelines do leave some room for stopping at a positive TTE in a stable patient with low risk of complications. But in general, I prefer the ESC approach, but depending on the clinical scenario, you can probably choose to apply either algorithm. And then finally, if the TTE is negative and clinical suspicion remains high, you should also move on to a TEE. So in the ESC guidelines here, really the only way to stop at a TTE for suspicion of infective endocarditis is if the TTE is negative and clinical suspicion is relatively low. So just a couple of other important points they mentioned at the bottom of the algorithm here that's I think relatively important. So if the initial TE is negative, but clinical suspicion remains high, remember that you might be early in the disease process and things can change over time. So consider repeating the transthoracic or the TEE within 5 to 7 days. And another important thing to note is that for right-sided endocarditis, remember that the tricuspid valve is anterior. So you can often get good visualization on transthoracic. And so for right-sided endocarditis, you don't necessarily always need to do a TEE. Okay, so our main framework for diagnosis is, of course, the modified Duke criteria, which can be fully applied after we have history, physical, blood cultures, and appropriate echo imaging. And recall that the criteria is divided into major and minor criteria. And based on the number of major and minor criteria fulfilled, a patient is then categorized into definite, possible, or rejected endocarditis. Here you see the major and minor criteria listed, and I just want to focus on the echo portion today. Echo evidence of endocardial involvement is a major criteria. And that's defined here as vegetation on valve or supporting structure in the path of a regurgitant jet or on implanted material in the absence of an alternate explanation. So an echo is also considered positive for endocarditis if it shows abscess, new prosthetic valve dehiscence, or new valvular regurgitation. And we're going to go through examples of each of those in more detail. So this is the diagnostic criteria used in the ESC guidelines, and it's very similar to the modified Duke criteria. But I just wanted to point out that the imaging section is just a little bit more extensive. So they also include in the diagnostic criteria for endocarditis, valve aneurysm, pseudoaneurysm, and intracardiac fistula. They also do include some multimodality imaging, so paravalvular lesions seen on CT, as well as positive PET scan in the context of prosthetic valves. So after you've applied the diagnostic criteria, again, you end up with either definite, possible, or rejected endocarditis. And so this is the second part of the ESC algorithm on how to select additional imaging tests for patients with possible endocarditis or with rejected endocarditis but ongoing high clinical suspicion. So the goal of additional imaging here is to really reclassify the patient as definite or rejected endocarditis on the basis of the ESC diagnostic criteria that we saw on the last slide. So for both native and prosthetic valves, transthoracic and TEE, repeating them are options. Imaging for embolic events is an option, so scanning the head or the abdomen. Cardiac CT is an option, with strength of CT being evaluation of paravalvular infection, more on that later. And the main difference here between prosthetic and native valves is really the utility of a PET scan. So it's an option for possible endocarditis of prosthetic valves, but not so much for native valves, and more on that again later. Okay, so before I move on to some imaging stuff, does anyone have any questions or comments that we want to talk about now on imaging test selection?
Yeah, if anybody have questions, you can use the chat room. I can ask Mike later, but perhaps you can go ahead, Mike.
Go ahead. Okay, we'll continue on. Um, okay, so we'll move on to echo imaging then, and we'll start with the basics. So when considering imaging findings in endocarditis, vegetation is really the first thing that comes to mind. So echocardiographically, the most important feature is that vegetation is oscillating, or it has independent mobility. In other words, it moves in a way that's independent of the cardiac cycle. So vegetations are often also irregularly shaped and of really variable size. The echo density is usually similar to the myocardium, but the echo density can increase with chronicity. And the wear is also quite important. So they typically form at sites of endocardial damage or pressure differentials, and so therefore have a predilection for valves, intracardiac shunts, and are often found in the path of regurgitant jets. They also tend to stick to the low pressure side of valves, which is also the side of the valve that sees more blood flow. So this is an example here of transthoracic images of an aortic valve and a mitral valve on the left. And you see maybe a possible vegetation on the mitral valve, but it's not clear. So this patient had Staph aureus bacteremia and had multiple embolic events. And so clinical suspicion of endocarditis was quite high. And so the patient did go on to have a TEE, which is seen on the right here. And it demonstrates independently mobile echo densities on both the aortic valve and the mitral valve. And the vegetations are really seen in their typical locations. So on the LVOT side of the aortic valve and on the LA side of the mitral valve. Okay, so remember that when we see an echo density adherent to a valve, it's not always endocarditis. There is a differential diagnosis. So tumor, thrombus, non-bacterial thrombotic endocarditis, artifact, degenerative changes. And so the next point I want to make is that, of course, clinical context is essential. So I want to show you a few examples here. So panel A is a TEE image of a aortic valve of a 31-year-old woman who had lupus and positive APLA panel. So you see an irregular appearing broad-based mass adherent to the LVOT side of the aortic valve. And it actually lacks independent mobility here. So she was afebrile with negative blood cultures. And so suspicion of infection was actually quite low for her. And so based on that, she was diagnosed with Libman-Sachs endocarditis, and she was treated with anticoagulation. And this can be actually a typical appearance of Libman-Sachs, although it does typically tend to have a predilection for the mitral valve rather than the aortic. Panel B here is a TEE image of the mitral valve of a 58-year-old man with metastatic lung cancer. Embolic events were initially discovered on staging scans that were just done for his cancer staging. So that led to echo and eventually to TEE. The TEE here showed some broad-based irregular echo densities on both the anterior and the posterior mitral valve leaflets. And so clinical suspicion of infection was quite low, and the patient was diagnosed with merantic endocarditis, and he was treated with anticoagulation. Panel C here is a TEE image of the tricuspid valve from an otherwise 43-year-old, healthy 43-year-old woman. This image is courtesy of Addie, it's still her case. So an echo was done initially for atypical chest pain, but it then incidentally showed a rounded mobile mass in the tricuspid valve. There were no endocarditis symptoms, but the patient actually ended up having 2 positive blood cultures out of many. And it wasn't really clear if the positive blood cultures were contaminant or not. So we suspected that this was actually tumor, possibly a myxoma. But given that endocarditis really couldn't be ruled out in the context of the blood cultures, she was going to be treated with 6 weeks of antibiotics with a plan to reassess the mass after a full course of IV antibiotics.
So Mike, I wonder if you can tell me again, like you said kind of a bit broad-based, kind of radial appearance. Like what's the appearance? Like if you see like one thing, what is the thing that points you towards endocarditis versus not? Like you talk a little bit about the clinical story, but like if you just look at it without any story, like is there something or some feature that you say, oh yeah, this is for sure endocarditis versus not?
Yeah, thanks for the question. So there's really nothing that will tell you 100%. You can never really say based on imaging alone. whether it's infectious versus non-infectious versus tumor, but there are some features that can point you in one way or another. So specifically, these two cases of non-bacterial thrombotic endocarditis of different kinds, you tend to see more sort of, again, like broad-based masses that have more of a stuck-on appearance to the valve. That can be suggestive of more kind of thrombotic type endocarditis or non-infectious endocarditis. And sometimes they can lack independent mobility as well. So, not always, but for example, the patient with lupus here, you can see that mass in panel A really moves with the valve and it's not really oscillating by itself. And that can actually be seen in non-bacterial thrombotic endocarditis as well. But again, it could very possibly still be infection. We can't say 100%.
Got it. Thanks.
Yeah, no problem. All right, so let's move on and talk about some common imaging challenges. So here's a case of a patient who is bacteremic with clinical suspicion of infective endocarditis. A TTE was done, which is seen on the left, and you can see some sort of an echo density protruding into the LVOT. So to investigate further, TE was done, and the image is seen on the right here. And you can see that the aortic valve is actually normal with no vegetation. So what we're seeing on the left on the transthoracic was actually side lobe artifact. So the clues pointing towards side lobe artifact here are that the echo density lacks independent mobility, and it's adjacent to an echo bright structure. You can see right in the center of the valve, there's this brightness. And you can also see echo density on the aortic side of the valve, and it really mirrors the findings that you're seeing on the LVOT side of the valve. And that's really typical of side lobe artifacts. So it's something to be aware of. It's a commonly can be misinterpreted as vegetation.
Like, do you need to get a TE, like if you see that artifact, or you're pretty confident it's artifact, right?
Yeah, it's fooled me many times. So I think if there's any uncertainty, then you can definitely go ahead and get a TE. But I mean, there are definitely some times when you can look at it and say that's almost definitely side lobe artifact and not get a TE. So I think it depends what it looks like.
The clinical context, if it's like high suspicion, you kind of have to go for it. Okay, thanks.
Exactly. This patient was bacteremic. I think they had Staph aureus, so it made sense that we had to make absolutely sure there's no veg there. Yeah.
Got it.
Okay, so myxomatous valves, they pose another imaging challenge. So myxomatous valves look thickened with redundant tissue, and there's often prolapse or flail. So the valve tissue can then have independent mobility, and so it can be really hard or even impossible to differentiate valve tissue from vegetation. And also, since these valves are quite abnormal, they're predisposed to infection. So they're both prone to infection, and it's harder to image them. That makes it quite challenging. As an example, so this patient had a myxomatous mitral valve and had recurrent bacteremias. So transthoracic is seen on the left and TEE is seen on the right. And you can see bileaflet prolapse with probable posterior leaflet flail and significant thickening and redundant tissue. And there's at least one echo density with independent mobility, but is it vegetation? Is it just redundant leaflet tissue? You really can't say based on these images, even with a TEE. So even a TEE was not really that helpful here compared to transthoracic in sorting it out. If prior imaging is available, then a side-by-side comparison can be helpful to look for interval change, but it's still hard to know for sure. In these cases, sometimes we really need to rely more on clinical features for the diagnosis. And for this patient specifically, so given their high index of suspicion, they had an abnormal valve, bacteremia, unclear imaging findings, they had symptoms. He was treated for endocarditis. So moving on to prosthetic valves. So prosthetic valves can pose challenges for a variety of reasons. So with prosthetic valves, immediately you have an abnormal flow condition. So regardless of the valve function, you never really truly recreate the normal flow state of a native valve covered with healthy endothelium. And so they're always prone to infection. Also, unfortunately, the sensitivity of echo, especially TTE, for detection of prosthetic valve endocarditis is reduced for a few reasons. And so one challenge is now the huge variety of valves and prosthetic material that can be seen in the heart, and we need to know what they should look like and what the flow around them should look like as well. So this is a patient here, an example of a patient who had prior mitral valve surgery and had persistent fevers of unclear source. So he actually had a prior annuloplasty ring and alveoli stitch, which is demonstrated on the 3D TE image on the right. But starting with the TT on the left, so due to artifact and shadowing, it was kind of hard to rule out vegetation. So he ended up getting a TEE, which is supported by guidelines. So on the TEE image in the middle, you can see this bright linear echo density protruding into the left atrium. And it lacks independent mobility, it moves with the valve. It's really where you would expect to see a surgical stitch for an alveoli type repair. And so that's what we believed him to have, was a surgical material rather than vegetation. So we're pretty confident with this one, but it's not always straightforward. Prosthetic valves can be associated with independently mobile echo densities that aren't necessarily vegetation. So things like loose sutures, prosthetic strands, subvalvular remnants can all be seen. Another challenge with prosthetic valves is variable post-op anatomy. So there can be surgery-related edema, there can be hematoma. These things can be really tough to distinguish from abscess. And so in those cases, it's really important to really compare imaging to previous studies available. And another point to note is that, compared to native valve endocarditis, prosthetic valve endocarditis is really characterized by a lower incidence of vegetation and a higher incidence of annular abscess and paravalvular complications. So it can be challenging to see on echo, especially when there's acoustic shadowing. And so if the diagnosis is in question and you're suspecting paravalvular infection, remember, cardiac CT can be extremely helpful. And I do have an example of that coming up soon. But first, I wanted to point out another imaging challenge that can be seen with prosthetic valves. So on the transthoracic image on the left, you see a mechanical mitral valve with some sort of an echo density protruding into the left ventricle. So could this be a large vegetation? It's hard to say for sure, especially because we're unable to assess the atrial side of the valve due to acoustic shadowing. So actually what we're seeing is called cavitation. So blood flowing through a mechanical valve can create microbubbles. And if a gush of microbubbles comes through the valve together at the same time, it can give you the appearance of a vegetation. So here the clue on the transthoracic study that this is cavitation is that if you look closely, you actually see more microbubbles sort of spread out throughout the left ventricle, but ultimately, it was unclear on transthoracic imaging, so a TEE was done, which you see on the right here, and it showed a clean valve, absence of vegetation. So this is cavitation, and give you false positives. All right, so we'll move on now and talk about complications seen on imaging. So identification of complications is essential and is really one of the primary goals of echo in endocarditis because many complications are indications for surgery, so it'll change management drastically. When we think about complications, it's really important to keep in mind the 3D structure of the heart because invasive pathogens can erode through heart structures. So take note that the aortic valve, the mitral valve, and the tricuspid valve are all quite close to each other. Pulmonic is a little offset to the front, but it's really not hard to get complications involving more than one valve. And keep in mind the location of the chambers and vessels relative to each other because fistulizing connections can occur. Also, again, remember that complications can develop over time. So if initial imaging doesn't show a complication, but the patient's status changes or clinical suspicion remains high, you may need to repeat imaging or use an alternate modality. Okay, so starting with valvular regurgitation. So endocarditis can cause valve regurgitation by really a variety of mechanisms. So bulky vegetations can result in valve malcoaptation. If there's subvalvular involvement, there can be chordal rupture leading to prolapse or flail. Invasive bugs can cause leaflet or cusp prolapse, perforation, tears. And often you're going to need a TE to really figure out the mechanism. So this is an example of a young woman who I think many people on the call might know of clinically. She delivered a baby by C-section and was diagnosed with chorioamnionitis. Unfortunately, she became bacteremic, and I think it was group B strep. So the transthoracic is seen on the left here. And what you see is mitral regurgitation in a non-commissural location. And the non-commissural location should really raise red flags that there's something funny going on here. In the context of GBS bacteremia, very, very suspicious for endocarditis. She moved on to have a TEE, which is seen on the right here. And what we see is a large multilobulated mobile vegetation with color flow moving through the base of the leaflet, with severe microregurgitation. So after a thorough TEE, we found that the anterior and posterior leaflets both affected with disruption and tear of the base of the leaflets causing severe mitral regurgitation. And so it was a complicated management case for her, but after really an initial course of antibiotics, she did go on to have a surgical repair. Okay, so perforation is a very serious manifestation of destructive endocarditis. So essentially, the infection erodes through leaflet tissue, causing a punched out or hole type appearance, surrounded by valve tissue, leading to significant regurgitation. And so you should suspect perforation again when you see an eccentric jet in a non-commissural location, traversing really a breach in leaflet continuity. So this is an example of a young man, 39 years old, with bicuspid aortic valve, who developed it was strep mitis bacteremia, potentially related to a dental cleaning. So on the left, you see TTE images of the aortic valve, and actually you see a two-dimensional gap in the non-coronary cusp. And color compare can actually be quite helpful for perforation. So you see significant color flow moving directly through the two-dimensional gap during diastole, diagnostic of severe aortic regurgitation. And the TE images you see on the right, they really show the same thing. Just possibly a small adherent vegetation, although in this context, it can be really hard to differentiate between destroyed valve tissue and vegetation. And then on the top right, you see the 3D TE image. And there you can actually see the defect in the non-coronary cusp that's surrounded by leaflet tissue, so diagnostic of a perforation. Okay, so moving on to intracardiac fistulas. So this is an interesting and dangerous complication. So fistulas typically arise from abscess that then forms a pseudoaneurysm and eventually ruptures, leading to a communication between two chambers. And again, this is where it's really important to keep in mind the 3D anatomy of the heart. So you can get fistulas in a variety of locations. Some examples would be, sinus of Valsalva to RA, LV to RA, that would be an acquired Gravoti. But really, fistulas can communicate with any chamber of the heart, as well as the coronary vasculature. So this is actually the same patient that we saw on the previous slide. So recall that he's a young man with an infected bicuspid aortic valve. And so, of course, patients can have multiple complications. So the TTE short axis of the aortic valve is seen on the left here. And what you see is some strange color flow entering the right atrium in the region of the aortic valve. And it's really easy to mistake this as tricuspid regurgitation. But in this context, we need to keep very high index of suspicion for a fistulizing connection. So on the right, you see TE images, short axis of the aortic valve again. And what you see is clear color flow entering the right atrium from the region of the aortic valve. And you see a two-dimensional gap there as well. And so that's diagnostic of an intracardiac fistula. So for this case, we actually found it pretty tough to distinguish the origin of the fistula. So it could have been sort of lower in the aorta or sinus of Valsalva, or it could be LVOT. It's tough to distinguish echocardiographically. But regardless, it was an indication for surgery. So he did go on to have surgery. And the surgeon actually described a non-coronary cusps to right atrial fistula. As well, he actually saw membranous VSD and the non-coronary cusp perforation.
Mike, can you, just wondering, if you just can use your mouse to point out where the fistula is, where your mouse was on the TE was just a bit more clear, right?
Yeah, for sure, for sure. So this is it right here. So short axis of the aortic valve. Here's the aortic valve. Here's the tricuspid valve. And what you're seeing is all this bright color flow in the right atrium, sort of coming from the region of the aortic valve over here. It's really not clear, and you see how you could easily just kind of go through quickly and say this is tricuspid regurgitation, but keeping a high index of suspicion, it's suspicious for a fistula. So here it becomes, on the TEE more clear. So here's the right atrium, tricuspid valve, and aortic valve.
And Mike, at some point, can you just discuss the role of CT scan for abscess or fistula?
Definitely.
Whether that is better or not as good, would just be interested to for the audience.
For sure, yeah. I've actually got a slide on that coming up with an example in a little bit. All right. Okay, so before we get to some multimodality stuff, we'll move on to prosthetic valve dehiscence and paravalvular leak. So prosthetic valve dehiscence refers to breakdown of sutures leading to partial or complete detachment of the prosthesis from the annulus. So it can be a catastrophic complication, and these patients can really tend to decompensate quite quickly. So look for paravalvular regurgitation and valve instability or rocky motion of the prosthesis, and keep in mind that it doesn't necessarily imply active infection. So valve dehiscence can happen for other reasons, and it's also possible that you can have medically treated or healed endocarditis that can weaken the annulus and lead to late dehiscence. So this patient here is an example. He had a surgical bioprosthetic aortic valve. He developed an episode of prosthetic aortic valve endocarditis, and initially was only found to have small vegetation on the valve. And so he was initially treated medically with 6 weeks of IV antibiotics. He then returned to follow up with these images. So the TTE image you see on the left, this is the apical 3 chamber. And what you see is the rocking motion of the aortic valve with a jet of paravalvular regurgitation. And so that's diagnostic of valve dehiscence. And on the right, you really just see the pathology in more detail. The right's the TEE image showing the same thing. So for this, he went on to have redo surgery. So paravalvular abscess is another complication to be on the lookout for. I hope this one comes across okay. So there's a clear predilection of abscess for the aortic valve, the aortic root. The mitral aortic intervalvular fibrosa is also a common location. So keep in mind for prosthetic valves, because of acoustic shadowing for the aortic valve, TTE really has actually better visualization of the anterior aortic valve, whereas TEE has better visualization of the posterior aortic valve. And if there's equivocal findings on echo, cardiac CT can definitely be very helpful. And again, I'll show you an example of that in a couple slides. So this was a woman with a prior bioprosthetic aortic valve replacement and an ascending aorta replacement in 2 separate surgeries. So she was initially admitted with septic shock and was found to have MSSA bacteremia. So TT images are seen on the left. So the valve you can see right here actually looks free of vegetation with normal function. I can tell you there was no regurgitation. Although acoustic shadowing does kind of limit vegetation detection here, but it's pretty good. But posterior to the valve, so here, you can see thickening. And there's kind of extensive heterogeneous perivalvular thickening that is suggestive of abscess. And it's really seen more clearly on the right, on the TEE images. And interestingly, so I'm going to point out this little mobile guy right here. So you can actually see that the infection extends into the left atrium. And what we're seeing there is probably a vegetation or perhaps veg-thrombus combination in the left atrium. So the infection is extending through the aortic roots into the LA. The thickening also sort of extends up the aortic graft, so consistent with perigraft abscess. So pretty striking findings for her. Definitely has surgical indication, but unfortunately her surgical risk was quite high And so the plan was for medical management for her up front. So yeah, I can touch on CT at this point. So this is actually I found this example in a study by Horgan and colleagues. It's an example of a prosthetic aortic valve where endocarditis was suggested. And a TEE was done in panel A, and it was suggestive, but not diagnostic of paravalvular infection. And so when we have kind of non-diagnostic or inconclusive echo findings, CT can be extremely helpful in this context, specifically for paravalvular infection. And so keep in mind that CT can also detect vegetations, but it can miss smaller vegetation. So if the veg is less than a centimeter, the sensitivity is significantly reduced. And so in general, for veg detection, echo has a better sensitivity. But for paravalvular infection, CT is really excellent. So in panel B here, what you see is a gated CTA that was done and actually clearly demonstrated a paravalvular cavity communicating with the aorta. So we actually was diagnostic of a pseudoaneurysm. It's something they would not have picked up of on this echo. This is actually the same patient, same case as the last slide. So the authors here also utilized a PET scan to prove that the pseudoaneurysm was in fact infected. So I'll just direct you to panel F. So what you see is a CTA fused with a PET scan demonstrating the proximity of the pseudoaneurysm to an area of FDG uptake. And so that's actually consistent with mycotic pseudoaneurysm. So in general, PET can be quite useful in cases of possible prosthetic valve endocarditis with unclear imaging findings. And it's important to note that the sensitivity of PET is actually rather low for native valves. There's a variety of kind of theories as to why. Nothing was clear to my knowledge. But routine use of PET is not really recommended in native valves, only really think about it for prosthetic material. So there's a few challenges with PET to be aware of. So first thing is that for the first 3 months after valve surgery, there can be sterile post-op inflammation, which can't really be distinguished from infection by PET. So it's not really recommended in the first 3 months post-op. You can also get false positives from vasculitis, foreign body reactions, neoplasms, non-bacterial thrombotic endocarditis, really any other type of inflammation. And you can also get false negatives. So if the patient's been started on antibiotics and the PET is done time after the antibiotics, it could be falsely negative. And so currently at Sunnybrook, we don't have cardiac PET, but we're actually in the process of getting it right now. And so hopefully we should have it relatively soon. And so the message is for possible prosthetic valve endocarditis, unclear imaging findings, consider PET to clarify the diagnosis. Just a couple more slides here. So a quick word on pacemaker and ICD infections. So this is really just a dramatic example of multiple vegetations on a pacemaker lead, seen on both TTE on the left and on TEE on the right. Overall, though, transthoracic imaging has poor sensitivity and specificity for detection of vegetations on leads. And it's really poor enough that if there's prosthetic or if there's a lead in place and there's suspicion of endocarditis, all of these patients should have a TEE done. But keep in mind that we often do see mobile, benign, kind of fibrin thrombi on device leads, not uncommon. And so a mass on a lead doesn't necessarily mean infection. So again, you need to use clinical context to guide you. And also keep in mind that a negative TEE doesn't rule out a pulse generator or a pocket infection. And so, typically they can be apparent on physical exam, but if you're suspecting a pulse generator or pocket infection, and it's not clear on physical exam and you need an imaging test and your echo is not showing any vegetation or anything like that, PET scan is actually the imaging modality of choice. So panels A and B here show fused PET CT scan for a suspected ICD pocket infection, which is confirmed by FDG uptake beside the device. Panels C and D show fused PET CT images in a different patient who had suspected device infection. And what you see is actually FDG uptake along the left subclavian vein as suggestive of infection. So wrapping things up, these are the main points that I hope I've gotten across. So first of all, which patients need a TEE? So really most patients diagnosed with infective endocarditis need a TEE to further characterize the extent of the infection, rule out complications. In patients with suspected endocarditis but negative transthoracic, if there's high clinical suspicion, you should go on and have a TEE. Also, if there's suspected endocarditis and there's prosthetic material of any sort or device, the sensitivity of TTE is really lower. So those patients should all go on to have a TEE as well. And if you're unsure, the ESC 2015 endocarditis guidelines and the AHA 2020 valve guidelines are really good resources. I think they're both great algorithms, and there's lots of information there. We should be aware of the limitations of echo and common imaging pitfalls. And if diagnostic uncertainty remains after echo imaging, one can consider repeat echo imaging. You can consider imaging for embolic events. CT is extremely useful if we're suspecting paravalvular infection. And PET scan can be useful in the context of prosthetic valves or pacemaker ICD pocket infections. And finally, keep the endocarditis complications in mind when reading the TTEs and keep a high index of suspicion. So just want to say quick thanks to Dr. Hansen. He gave me some guidance and helped me prepare this talk. These are the references that I had, and that's all I have. So we can move on to any questions or any discussion.
Great, Mike. Maybe I'll have you take down these slides and we can have some questions and see everybody a bit better. Cam, do you want to ask Mike some questions? The echo folks.
Mike, I think that was a great overview of a complicated evolving area. Any comments on TAVI endocarditis? We see so many TAVI patients here. Marco and I were talking about this yesterday. For some reason, we don't see a lot of endocarditis, but
yeah, for sure. I think I did. So you mentioned that study that was in JAC just this month. So I had a quick look at that. Yeah, I think it's interesting. I mean, first of all, one of the main points is that they're sick patients. If you have a TAVI valve and then you go on to have endocarditis of the TAVI valve, first of all, you're kind of in a situation where you were not maybe a candidate for a surgical valve, and then you have endocarditis on top of that. So the patients generally don't do well. Most of them were treated medically. And that study actually suggested they didn't actually find much of a mortality benefit to surgical management. But in terms of imaging and diagnosis, I think that one of the main distinctions to point out is paravalvular leak. So, because of the way a TAVI valve is implanted, there's no sutures. Paravalvular leak can be more common. And, it's a marker of increased mortality for those patients, but it doesn't necessarily imply a pathology or imply infection. Whereas for a surgical valve that's been sutured in, paravalvular leak is always abnormal and always needs to have further workup and can be more of a concerning finding. So in terms of diagnostics, that's kind of the distinction I'd make. I don't know if you have any other points, Dr. Joyner.
I think because of the echoes that you see from the frame of those valves, they really all need a TE if one is concerned about endocarditis.
I'm just wondering if those like Harendra, it is true, TAVIs doesn't really have many, we do so many TAVIs, we don't really see many come back with endocarditis, nor we see a lot with surgical, but is it just perhaps there are no sutures and things like that? Would that reduce their chance of endocarditis? I don't know whether Harendra knows it as well.
So we were part of the series on this. So Rhodes Cabot is a real research interest, and we've contributed quite a lot of our cases to them. So I don't know if that's actually true to say that that the incidence is lower. We generally don't do TEEs in those patients, so it's almost always a blood culture that meets the Duke's criteria, and then ID recommends treating them for prolonged course, like we would with endocarditis. For our patients that have had endocarditis, we've never had one where the TAVI valve has deteriorated to the point where that has resulted in a demise or we've had to do something about it. that being said, paper that Mike has, I think, is the most recent one from Cabot's group. Like he's had, like we've sliced this data in every possible way possible, but the mortality from it is actually relatively high. We just haven't seen that in our own experience. So I do think it needs to be acted on quickly, and many times you don't see the echo findings that Mike has recommended, probably because there's a big TAVI frame there, but we treat them on spec as they have endocarditis. And right now in hospital, we actually have a patient with TAVI endocarditis on medicine that's being treated for a full 6 weeks. And that patient actually had splenic infarcts as a result of the TAVI valve being seated.
And Harinder, did that patient have a TEE?
No.
No.
So Marco knows the patient. There was a discussion about it, and we decided not to again. So from a hemodynamic standpoint, patient's fine. Lots of other problems, but hemodynamics is fine. And we're going to treat them for a prolonged period of time. So my recommendation was not to put them through a TE.
Yeah, maybe we can chat quickly after, because I think I have them scheduled for a TE at 11.
Oh,
Okay,
they ignored me.
Yeah.
let's move on. I think Mark and then Kareem have questions for you.
Just Mike, that T this today is for a different patient, just FYI.
Oh, okay.
So just two quick comments. The first is distinguishing between the vegetation and infection versus other etiologies of masses. But now it's true that you can't, see microbes on a TEE. What you can see, though, are some of the hallmarks of infection, which are in the classical is new pathological regurgitation and destructive changes. So if you see evidence of degradation by inflammatory enzymes, that's a pretty good clue that the infection is present, whereas masses of a non-infectious etiology may be stuck onto valves or interfering with a motion or occlusion of valves, or etc., but they're not usually destructive. The other comment just to make to the trainees who are in the audience, I would strongly encourage you, if you encounter a case of endocarditis that does go to the operating room, make every effort to at least see intraoperative images, or if possible, go to the OR, because you really learn something quite different from what you see on imaging if you actually see the pathology in real life. It's worthwhile doing at some point in your training if at all possible. But anyway, Mike, congratulations.
Thanks.
Kareem, maybe go ahead.
Hey, Mike, great presentation. Happy to have you at North York next year, or coming up in the next few months.
Thanks, Kareem.
No problem. So the question I had was, one, I guess we were on the topic of TAVI. I mean, are we really seeing many endocarditis with clips, tricuspid or mitral? When I was at Mayo, we were thinking about studying that, and my understanding was the incidence was low, and I guess it may be similar to TAVI. And then I guess also in terms of PET, have you guys? You said it's starting up, and have you sent to other places to get it done if need be, or what's been your approach?
Yeah, for sure. So for clips, I actually haven't seen a case of clip-related endocarditis this year yet. I'm not sure if any of the clip team is on the call and can comment further, but yeah, anecdotally, I haven't seen any cases yet. I don't know if Dr. Joyner or Dr. Hansen reading TTEs have seen anything, but we haven't gotten any TE requests for that. Yeah. In terms of PET scans, so we're in the process of getting it. I think we just are waiting for some approval. My understanding was sort of we're looking at a month's kind of timeline.
Okay.
I'm sure Harinder would know. But yeah, for now, I think cardiac PET should go to probably Toronto Western.
Gotcha.
Yeah.
Marco, you have a comment? Go ahead.
We haven't seen infection on MitraClip done at Sunnybrook, but we have seen infection on MitraClip done at St. Michael's, just for the record.
Gotcha. I have not seen any in my time, so.
You haven't either? Yeah.
The competitive environment. Perhaps, Mike, one of the other things that people kind of talk about is that, well, what they, this person has a very high index of suspicion of endocarditis. Why don't we just go ahead and do a TE, and you need it anyways? Like, what's your thoughts? I think logistically it's probably not feasible, but I don't know whether you have thoughts about just going straight to the TE when you think the person definitely have it. With your echo images, most of the time it's not diagnostic.
Yeah, for sure. I mean, honestly, practically what would be probably the most ideal thing to do is just do a TTE and a TEE at the same time, because, honestly, a TEE should be coupled with a transthoracic study. They really provide complementary information. So yeah, if there's a patient who has high index of suspicion, I agree. You're not going to get away without doing a TEE. And so it would be reasonable in those kind of situations to consider doing just TT-TE together up front.
Oh, that makes sense.
Yeah.
Cam, do you have any other comments?
No, other than Mike, I think it was a great presentation. Thank you for your perspective. I don't know whether Addie has any comments about multimodality imaging. She's on.
No, I think Mike covered it all.
Have you seen patients go to Toronto Western for PET scans, Addie?
I don't know. I'm not working with the nuclear team, so I have no idea. But I think they're going there. We are not doing PET in Sunnybrook right now.
Right.
A few times in the past couple of years, we've sent them to the Western.
So thanks. I would like to thank Mike and the ECHO team for doing these rounds. I know like these images are fantastic. It's one of the best talk I've seen, to be honest, on endocarditis. So I really appreciate, despite not reading echoes, like it's fascinating. It's great. I learned a lot. So I really want to congratulate you, Mike, for having a successful fellowship. Make sure you continue to refer patients to us. I think that's always the case.
Sure,
but thanks, everybody.
Thanks
Everyone for coming. See you later. See you next week. Bye.
Yeah.